presenters. We're now going to the second part of our session, and that's the planning framework, human resources, and stakeholders inclusion. And this includes time planning. So I have a panel that's going to cover this very broad area. So could I ask all the panelists who are here present to please come up to the podium? And then each panelist, you will tell us who you are and give the key highlights of the area that you're going to cover in 3 minutes. So I've calculated that if we do this, I think we'll be able to catch up with our time. So with that, let me start on my extreme right. Sir, a privilege, the lady.
Thank you. My name is Viwale Alfred. I'm the program manager for the National Expanded Program on Immunization in Uganda. We introduced HPV vaccination in a very coordinated manner. And what helped us to coordinate was having one plan against which all the various resources were pooled. For example, we got resources through WHO, UNICEF, PATH, CHI, and funds which are directed to the Ministry of Health. But one plan helped us to coordinate this. Number two, in terms of partnerships, the structures which we used for deploying the vaccines helped us to know which stakeholders to engage. This school health program is a very strong platform which we use, and Ministry of Education is a very key partner in that. So we work with schools and vaccinate in school setting. We also have vaccination in routine facilities, but the uptake is very, very low. And we also use the Integrated Child Health Days platform in the months of April and October, and 80% of children who are vaccinated in Uganda are actually vaccinated in those 2 months. And this requires full engagement of community structures through the local government entities, which is the body mandated to provide health services to the people. Finally, as a constraint moving forward, the issue of digitizing immunization data becomes critical. Information which is kept on paper is not retrievable and is not easy for analysis. And some of the dropouts are actually people who are either already married or they have fallen out of that group. And lastly, the challenge of targeting at the beginning. Initially, we had, do you target by class or do you target by age? And the definition of the cohort was a real headache, but we had to later on take a full stance that at 10 years, that's when we give the vaccine. So I think this is where I would stop. Thank you.
Thank you so much. Good afternoon, everyone. My name is Lucy Kiare. I am a technical officer with JSI. So I supported Kenya when we were introducing HPV vaccine in 2019, and was backstopping for Mozambique, still backstopping. So in my presentation, my brief presentation, I'll just talk about the lessons that are coming from the 2 countries, and maybe give one example of how partnerships can be leveraged. So in the morning we had, So in the morning we heard from Stella and we heard from Dr. Innocent. So I just wanted to bring out some of the things that I heard from the presentations that I have also experienced while supporting the programs in the 2 countries. And one was especially on difficulty to push activities. For example, you've invited the Minister of Health. So that's aligning with the plan in place. So my question was, do we compromise if it's not, so I had actually crafted a name from that. So we are ready, politically ready, but technically not. Remember, we talked about the readiness assessment. We were not ready to introduce, but then we've invited very high level people. We cannot tell them not to come, but we are not ready. So do we compromise the quality and go ahead with the ceremony? And then, so after the ceremony itself, the ceremonial launch, what happens after that in terms of planning? So, and then I've seen in terms of human resource for health, so I've seen we use cascaded training. Most of the countries introducing use cascaded training. We've heard about the diluted quality of the training when it gets to the implementers who are very key. So I just wanted to share an example. In Kenya, the healthcare workers have been using WhatsApp groups, and they have been effective. They are at different levels. So we have WhatsApp groups at the national level, at the sub-county level, at the county level, with community health workers, as well as between health facilities and teachers. So what happens in terms of if there are any questions that need ready answers, they're posted in the WhatsApp group, and healthcare workers are able to respond to them in time, as well as during parent-teachers association, especially with the health facilities and teachers. When there are parent-teachers association meetings, you find that teachers are invited, healthcare workers are invited to go to school and talk about the vaccine. So the last one is on partnerships. And I just wanted to say in a nutshell, we have to be very intentional and committed to identifying strategic partnerships. And I wanted to give an example in Kenya. So there's a technical working group for adolescent health and teenage pregnancy. I know Dr. Innocent mentioned the list of stakeholders that were part of the introduction. When he was speaking, I was checking the box. So the technical working group for adolescent health and teenage pregnancy has all those members that were listed. So the multi-sectoral approach is avoiding fragmented implementation of program, as well as implication of intervention, and it also leaves. So as I was reading again, just to link that, I was reading and I came across an article that one of the counties, we have counties, so it's called Kiambu County. It has adopted a model to improve healthcare for HIV-infected children. It's called Cheer Up Program. So I thought the children might be between the 9 to 14. Have we been tracking the HIV positive girls or girls with immunocompromised health? Are they getting the 3 doses that we require? So we could actually form partnership, and you can see this is Kiambu County. It might not work in other counties, so it's context-based strategy. Thank you so much.
Thank you very much. Please can we give her a round of applause?
Thank you very much. My name is Furaha Kiesi from Tanzania. And Tanzania managed to introduce HPV back in 2018 in April. And among the things that really were crucial was timely planning, as the topic says. And what really helped us in timely planning was contributed to providing much of a better and a quality work, because we could plan, make mistakes, and then replan, and kept on like that. And at the end of the day, another issue was prioritization in terms of what important tasks were to start with in terms of introducing HPV. And we had to prioritize on all important tasks by keeping them at the highest priority. In issues of planning, we had a multi-sectoral approach in terms of involved the Ministry of Health, Ministry of Education, and other stakeholders, which we thought were important in terms of having a good coverage. And since we planned for both school-based as well as health facility level vaccination, we managed to align well with the school health programs as well as the community, so that most strategies were tailored to that particular area. Of the most important thing, as you say, on planning, was issue of during the micro planning is the involvement of the community and the schools themselves at the ground level, which really helped us in getting a good coverage on that. For the second one, which is in partnership, we all know that this partnership is very important, especially in the immunization program, to succeed. And we could categorize them at the national level, the regional level, as well as the council level. And it was also important to involve public-private partners, which included radio stations, TVs, media, We also have what we call VCOBA. I think most of you are aware, the village community banks that were really helpful to spread the word and also during demand creation activities. In terms of community partnership, we all went down up to the community level, whereby presence of community health workers, which were able to link the students, the out of school girls to the system so that it can be well vaccinated. Challenges, they were there. Challenges were there, but as any other places is we were sort of, as I said, we are planning, looking at the challenges or mistakes, and then we do replan. And the most important challenge was to align what has been talked at the national level to be cascaded all the way to the community level. Thank you.
Yes, good afternoon. Chris Morgan. I'm speaking from the perspective of Japago, that supported half a dozen or so countries in Africa, but also Pakistan and India. Pakistan is on a very long, slow road to HPV vaccine introduction. And I think timely planning is really critically important there. From looking across countries, I think one approach that seems to have worked well in identifying partners is to take a leaf from the HPV world of this settings approach. So you look at the setting where you want to deliver the service and look at who else has an investment in health in that setting. And we particularly learned from Tanzania, so I'm glad to follow Dr. Kieshi. A couple of things that I wanted to add. One is that for the delivery in schools and trying to deliver other services alongside HPV, one of the keys seems to be that they formed a very tight, small group of technical experts at the national level that went both for immunization and education, but also some of the other areas important, like nutrition or adolescent health more broadly, and use that really tight group. So Dr. Mary Rose down there was one who was telling me about this, to come up quickly with the implementation plan that would support that. And while I'm mentioning Tanzania, I think they also found a way to include boys, even though the boys did not get vaccinated. This is in pilots in a couple of regions where the education sessions run before the HPV vaccination were specifically directed to boys and girls, and then the girls got vaccinated. So it's a way to do something for the boys as well as for the girls. Across most countries, and this is proving absolutely critical in Pakistan, involvement of professional societies has been a window into both gynecologists, professional midwife societies, pediatric societies. That's been a window not just into them supporting HPV vaccination, but also a window into where are the private practices, where are the other partners that would be involved. And I think looking around, there's quite a few members of different professional societies here, and it's something that could perhaps be boosted for private sector engagement. Two more points very quickly. One is, from what we've seen, the investment in social mobilization you make has to start 6 months before, if you can. Whatever budget countries think of is good for social mobilization generally needs to be doubled or tripled because it is so critical. And the last point is that these investments in social mobilization can't come just at the beginning, they need to be sustained. And what is really difficult in Gavi's systems, I think, is this, how do you differentiate the one-off spending you do at the beginning under the vaccine introduction grant with the spending support that's needed to actually keep the program running in the long term? I think that's an issue that's not yet been solved, but thank you very much.
Thank you very much. My name is Temwa Mzengeza. Hello? Yeah. Thank you very much. My name is
My name is Temwa Mzengeza, responsible for routine immunization in Malawi in the EPI program, Ministry of Health. First, I'll talk on planning. When we were to introduce HPV in Malawi, we also had two other introductions, the malaria vaccine as well as the IPV. Instead of taking this as a disadvantage, we took it as an advantage. And because of that, we could integrate what we could integrate in terms of planning, the meetings and the other activities like the micro plans, like those that we could integrate. We took advantage of that and we leveraged the resources. So it helped in our planning framework instead of doing the things in isolation, and they could take much and more of our time. Partnerships are, of course, key stakeholder, Ministry of Education. Without them, HPV would be very difficult to execute. And when we look at the other partners, regardless of them being involved in the immunization section, but as long as they have a stake in cancer issues, they are the perfect ones to partner with because they have stake. And the other, I will still call in courts are the parents, the guardians of our girls. When we were introducing in Malawi, we set our records in our education sector in the school, where we could have the ages of our girls in their registers. And we were quick to pick on those ones for the eligibility of our girls, but we were wrong. We had picked others who were not of age, others who were out of age. Why? Because as the children go to start school in Malawi, they have to click 6 years. And if a parent would want that child to still be enrolled in school, they would give the correct age. But then that is the record that is in school. So they are also a very great partner as far as age eligibility concerned. And lastly, I'll talk on human resource. We have a very huge amounts of health workers, community-based. We call them health surveillance assistants in Malawi. What was needed was to just give them the capacity on HPV vaccinations, and they were really instrumental, and they are the ones that could conduct the vaccinations, but with the knowledge and the information that they need on the for the HPV vaccination. Thank you.
Thank you very much. There you are, colleagues. You have it. Those are the panelists. And I'll now open up the floor for any questions or comments. And if you have a question, if you are able to just say who you are directing it to. And also to remember that we had the two presenters at the beginning. So they are also part of this session. So remember them as well. Okay, so the floor is open.
All right, maybe one small announcement.
Yes.
All right, just to remind everybody, there are some online participants and this session is also being recorded. So please speak into the microphone just so that everybody is able to hear you. Thank you.
Start at the back. So I'll have you, ma'am, and then Meseret, and then is there a hand up on my left side? Yes, thank you. So my equity project is working. All right, so I'll take you. You have the floor. And then after these three comments and questions, panelists and presenters, please be ready.
So first of all, I'd really like to thank the presenters for that work. And as much as we're talking about success, it's clear that success is on the way. One of the things that really impressed me is that from Uganda, you told us that 80% of your doses are given, is it 2 weeks or within a 1 month period? So that data said to me that if we have a one dose regimen, we can literally be doing this in a campaign mode over a very short period of time. My question is, might you have costing for that? Because recurrently, resources is an issue. Thank you very much.
Dr. Flo, then Bella.
The presenters, but mine are few comments. So when we mention professional societies, the different countries have made success, amazing success. So pediatricians, gynecologists, the teachers or educators. But the media, always when you see in the introduction plan has the highest budget. Why are we failing to make sure at least the public media would give us service? It's doing service to the community. And I think they should be influenced to work for free. That's my humble suggestion. What is their contribution to public health? So that way, we would have really paid for those to make sure the vaccine goes to the remotest place and we could save money. So that's what I want to challenge the new introduction countries or those who are going to scale up. The second was the clear role of the educators or teachers and the healthcare practitioners is very important. Otherwise, we are like overlapping sometimes. So two, I admired the work in Ethiopia because though they do it in school campaigns, they are not paying PSC. So I think as we institutionalize, we have to come out of this campaign paying because then the remaining money could reach those who need to be reached. So these are the few contributions I wanted to bring in. Thank you.
Those are contributions not directed to any panelist. Bella.
Thank you very much, Rose, and thank you to the presenters. Wonderful presentation, and I think it's taking shape now on how we are going to be moving forward. I just wanted to stress the importance of project implementation programs and institutionalization of the HPV vaccine programs into the Ministry of Health or Ministry of Education. I just thought that once Gavi gives us some of these vaccines, we roll out the program. At some point when they don't have the money to give us for these programs, we are going to actually go down again. I think in Zambia, we experienced a downward trend in HPV, but not because Gavi didn't give us the vaccine, but we had other programs that actually took over, like COVID. We had a change of government, and so even high-level discussions and things like that were affecting the program. So I was just wondering, because I'm not hearing how we are actually incorporating HPV vaccine program into the national strategic plans so that it does get funding from actually Ministry of Finance of those countries. And also, these two strategic plans for Ministry of Health and Ministry of Education is key. I know that the roles and responsibilities need to be highlighted, but I think if we put it in both strategic plans, we might be able to get some resources for sustainability of the HPV vaccine program. Thank you.
Right. Let me come back to my panelists. Uganda, you have a question. And then the comment from Zambia, I'll give that to Japaiko to handle, unless someone else wants to take it. Japaiko, be on standby. Okay, Uganda.
Yeah, I think the question of using one dose or not is a question of science and what the efficacy is, and that line will leave it to the scientists to conclude. But from a program perspective, all what we need to do is how effectively we can deliver the vaccines to the target population. We have over the years, over the last 4 or 5 years, our coverage for HPV-1 is above 90% and consistently. The challenge we are getting is with the second dose, where we have a high dropout rate of about 50% or so. So the first dose, access is not the problem, but taking the program up to the end is the challenge. So In terms of if the science answers us that the one dose is very effective, then it becomes cheaper to deliver the vaccine. And also in terms of effectiveness, we will be there. On average, for us to engage in a vaccination activity, where you activate both the supply side and mobilizers to mobilize at the community level, you need between $3 to $4 million. So if you're vaccinating in a school setting, then the mobilization side is off. So it becomes cheaper to do it in school setting. And as I said, the 90% coverage, 80% of it, we get them in school setting. So for us, the issue of institutionalizing the school health program as a platform to deliver HPV becomes more important than ever. Probably I need to go to the issue of sustainability. These programs are largely supported through Gavi support. We know that countries are transitioning, and this is a big risk for the program, both for financing the vaccines and also the programmatic deployment. So more efficient ways of delivering the vaccine to the target population is what probably we need. Right now, HPV deployment is benefiting from other initiatives in the country. For example, we have the Integrated Child Health Days, whose package includes all the vaccines and other supplementary feeding programs like deworming, vitamin A, and so on. So when we plan for 1 week, the first 3 days we target schools because the children are already mobilized. And then we spend the remaining 3 or 4 days looking for those who are in community setting. So it has paid us very well.
Thank you, Japago. And from up here, what do you call Tanzania?
Sure.
All right, good. Here we go.
Comment on the media, I think, was very pertinent. And I think what we've heard in a few countries is the media can change governments, they can alter opinion, they actually have power. And they need to be brought in not just as a channel of communication, but as a stakeholder partner who can help actually shape the program. And to go outside of Africa, in Pakistan, we've learned this the hard way, and they need to actually come in as a key partner. I'd like to comment too about teachers. And I think in Côte d'Ivoire, we saw a little bit of this in the presentation, that Ministry of Education is just as complex as Ministry of Health. And so there was a need to engage the part of education that helps organize things to help organize the school visits. Need to engage the teaching part, particularly the teachers who teach on health. Also need to engage the school health part, which is a different section altogether that actually provides school health programs and has health workers working for Ministry of Education. So that was a lesson that actually took time to learn in Côte d'Ivoire over the first year. And Dr. Valepi's point about for sustainability, embedding in Ministry of Health, absolutely, and Ministry of Education strategic plans is absolutely critical. And I think one thing that was interesting in Tanzania is you mentioned the national, regional, etc. levels, so that in decentralized settings, it's actually got a slightly different feel or more expanded feel to how you embed HPV in government strategies.
No, you took all of my points. Yeah, so he completely said what I also wanted to say, but I totally agree with what you had mentioned regards media. And in terms of, for Tanzania, what we did actually, we thought it should be a very multi-sectoral approach, involvement of media, professional association, and actually we use what we call MEWATA to spread more word, because we know that once the girl or the woman goes to her healthcare provider, and if the healthcare provider is not speaking the same language, it might have some issues as well. So we did a multi-sectoral involvement. And we have what we call the PORALG. PORALG is the President's Office and local government, of which is it's sort of supervising all the health facilities as well as schools. So it was, we thought we got a lot of good coverage and good uptake because of that involvement. I really also appreciate what Cote d'Ivoire had mentioned with the ministry that they also involved. There were so many, and we feel like Tanzania, while doing the MAC, we will take that example. Thank you.
Thank you very much. So just for me to give a very quick summary about our session. So the first presenter covered the challenges to vaccine introduction. Our second presenter described very clearly the upstream determinants. And then when it comes to our panelists, Uganda, you emphasize very strongly the importance that the school health program plays. And then Kenya, leveraging partnerships. And then you also talked about how you used a very efficient WhatsApp group and how to get, working with the Parent-Teacher Association. And then also you mentioned that we have a lot to learn from the HIV program. Tanzania, you reiterated the importance of timely planning and the prioritization, but also very strongly talked about involvement of the community and radio and media. And this was also echoed by Japaigo. Japaigo, the settings approach that we can learn a lot from HIV. And then also I think very importantly is that the education sessions in the schools are a very good opportunity to also get the boys to know about HPV and vaccination. And also, I know in some countries, this also brings in the other health aspects like hygiene and so on, but HPV vaccination being the foundation. And then, Japaigo, again, you mentioned the involvement of the professional societies and also making sure that the private sector is also on board. And then social mobilization, that you don't start your social mobilization activities just before you launch, but you said something like 6 months, and that it should be well funded, and then it continues, of course, throughout the implementation of the program. Malawi, also unique experiences to share, that HPV vaccination was introduced the same time as IPV and the malaria vaccine, and how you managed to handle these introductions all at the same time. All of them happened. I mean, I was in Malawi at that time, so I do know. I'm testament to that. So with that, colleagues, I would like to say thank you for your listening and participation, but especially to the presenters and the panelists and my co-chair. Thank you very much. Can we give ourselves a huge round of applause? Thank you. The session is closed.